Welcome to Coffee and Conversation, put on by the Mahaska Chamber and Development Group. I am Paula Falconer, Community Relations Coordinator for Mahaska Health and a board member of the Mahaska Chamber. We want to thank the following businesses for making today's event possible. Midwest One Bank for sponsoring the coffee, Smoky Row for use of the facility, George Daly Auditorium, Andy and Allison McGuire for setting up the sound. We would also like to thank any media that is present. We also want to thank the American Legion, who will now lead us in the Pledge of Allegiance.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. The panel for this morning includes representatives from Mahaska Health. We have Dr. Trish Mona, Family Practice with OB and Birthing Center Medical Director. We have Dr. Taylor Schwartz, Summers, OB and GYN Physician, Dr. Timothy Brion, General Surgeon and Chief Medical Officer. We're missing Dr. Gritters, but we do have Kevin Durande, Chief Executive Officer, and Sheriff Russ Van Renterghem. I will turn it over to moderator Mayor Dave Cruzfeld to get the forum started.
Good morning, everybody. Thank you for being here. From time to time, it's good for us to go back into some of the more local issues that are going on and have an appreciation for some of the more local efforts that are happening. We spend a lot of time talking about state policy and some of the ideas that are floating around there, but we also need to have some sort of appreciation for what's happening in our own area. And so I'm looking forward to this session in particular because it gives us a chance to ask the kinds of questions that we think about when we're at home, but we don't actually get around to asking anybody. And so I'd like to open things up first with some comments from the panel. Would you like to introduce yourself and then just a couple of words about what's happening in your world?
Good morning, Kevin Durande. It's great to have you here today. A few updates on the hospital. We're thankful to have two new OBGYN physicians at our facility, Taylor and Gar Summers. So excited to expand OB services and really take care of a lot of women for GYN services as well. Also, we have a new cardiologist that started, Dr. John Pergolski. Full-time cardiology, very thankful to have that service in our community. And Dr. Pergolski moved back to Iowa, and just like Taylor Garth, we're thankful to have some local physicians that are living in our community. So.
Good morning, Tim Brion, General Surgeon and Chief Medical Officer. I'll just field some good questions, I'm sure. A lot of things we can talk about, a lot of stuff going on, not at just Mahaska Health, but with healthcare in general. I know you probably have a lot of questions, and so do we. So we'll work on some of those together.
Hi, I'm Taylor Summers. This is my first one of these, so I'm really excited to see what this is like. OBGYN physician. My husband is the other OBGYN physician that is in town. And really, we've had a blast since we started in September, just expanding access to women's health care, bringing our infertility practice here and taking care of those patients that desperately need those services, We've really hit the ground running, and we're continuing to grow and expand our practice, and we really enjoy taking care of the women of Southeast Iowa.
Russ, Renterghem, as far as the sheriff's office goes, probably the biggest change that we've been dealing with in the last 4 months is we had a couple of long-time deputies retire. You guys know Scott Miller. He hung it up after 38 years with the sheriff's office. And Matt McCain just a month ago hung it up after 27 years. So we're working on getting those replaced. The face of the sheriff's office has really changed. You know, like Scotty was there, I mean, he was there when God was a baby. he was a staple, and there's a big shoes to fill. So that's probably the biggest challenge here recently is getting those positions filled.
Hi, I'm Trish Milner. I'm family medicine and OB physician. I'm the OB medical director. I'm actually not an Iowa native. I moved here from Hawaii with my family, and we are working on expanding, as Dr. Swart said, the services in OB across Southeast Iowa. We are in the OB desert, so we're really focusing on areas like Keokuk County, Tacoma, Keokuk County, and we're really working on diversity in medicine for OB. We're working at the State Department level as well, with coupling with the IMQCC for improvement in OB standard of care in Southeast Iowa as well. So I'm really happy that the new OBGYNs are here to help lobby for changes that need to be made in maternity care, especially in the rural area where it's really needed. And I look forward to your questions.
Thank you very much. So I think you all know the rules of the road on this, and I'll be walking around with a microphone. When I get to you, for you to be able to ask your question, I'll hang on to the microphone. Please introduce yourself by name and then also where you're from. That gives us a little bit of perspective as to where you're coming from with the questions you ask. Who would like to get us started this morning?
Good morning, folks. Eric Palmer. I heard you just say you were expanding the fertility clinic at the hospital. Did I hear that right? Would that involve things like IVF and so
on? So my husband and I are trained OBGYNs, not reproductive endocrinologists and infertility specialists, but we trained under those physicians when we did our residency at the University of Nebraska. So things that we can provide for women when it comes to fertility services is we use oral medications, some injectable medications. We help them learn about their cycles because a lot of women don't understand their menstrual cycles and how and when they can get pregnant. And we also provide intrauterine insemination services. So not IVF, not creating an embryo outside of the body, but it's actually helping the egg and the sperm to meet to be able to help people grow their families.
Next question. Not seeing you, wave.
Good morning, Helena Hayes from New Sharon. I do represent the Iowa House from this district, Mahaska County, Keokuk County, all of it, and Jefferson County. I'm pleased to get to be on this side of the stage this time, and you guys can be in the hot seat. I hear a lot of this type of language. You know, we hear a lot of it. You know, we are a desert for apparently a lot of things. We're a child care desert, we're an OB desert, we're this, we're that. Would you just take a moment to describe what you mean by that statistically? And as we try to understand our perception, you know, how we perceive what is happening in our community and in Iowa, I guess I want to challenge sometimes how we perceive. Because I feel like the narrative oftentimes is very negative, and then we create perhaps realities that don't exist. So I'd like to understand what that means, and we talk a lot in this Capitol about rural health care, especially, And so when we look at Cape Cod County, which is very rural, less than 10,000 people in the whole county, which is less than what is in Oskaloosa, especially that area, because you're servicing more and more of that area. So I know that's kind of a multitude of questions, but help us to understand what Mahaska Health is doing, because I think you guys provide a fabulous service. I feel like in our area, people don't have problems getting access to hospital care. And so please expand on that for us.
Thanks, Ellen. You know, it's a great question. Questions. You can rest assured that every day we talk about that very thing. It's kind of the center of all of our executive team meetings and provider meetings. We have provider-based meetings that are talking about how to be able to take care of our region of patients more effectively, more efficiently, getting them in, getting access to other providers not in our facility, so that we can help other facilities to take care of patients when they can't find places to take care of their own patients. And so we want to be expeditious, we want to be efficient, we want to be appropriate, and we have a yes policy. So as far as we can, and within our resource window, we try to say yes to anybody that needs care. So why do we do that? Well, for the reasons you said, there's a lot of concern about rural areas and the delivery of healthcare services in a rural area. And many people would believe that healthcare services are challenged in rural areas, and that's true. You can go from one county to the next, and the ability that you have to gain access to healthcare is extremely varied. And when I was a medical student, I looked at rural surgery in Iowa. It's been quite a while ago. And did research on that and learned that there was a shortage of general surgeons, but also a lack of ability to train general surgeons to do the kind of care that general surgery communities needed. Having a hard time doing that because everybody still disagrees on how to train and how to do that. But we talk about it all the time. And so if you go around here, you don't find many hospitals that do OB services, and that's a problem. You find less surgeons that want to be on call 24 hours a day, 7 days a week in surrounding communities. That's a problem. And we have been talking about that for a long time. We actually have now more FP and OBGYN, OB services at our facility than we've ever had for a long time because of that. We're reaching out, and I'm going to have Trish and Taylor talk about that some to finish this question. But I believe we are trying to address that from an OB care standpoint because it's really challenging when you're a mother that's pregnant that lives in southeast Iowa and you have limited options on where you can even deliver now, which has changed significantly in the last 10 to 15 years. My grandfather passed away when I was in second grade in our ER because of a ruptured spleen, and we just were simply not able to take care of that because of no blood banking abilities and because of limited surgical abilities. That no longer happens. That's not been that many years ago. 50 years ago, things have changed a lot in 50 years. And so every day we're talking about how we can right-size medicine, right-size surgery, right-size patient delivery, because we want to be an island in an area of surrounding rural Iowa communities that are challenged in how they deliver care, and we have to address it head on, because if we don't, really nobody else is. It's getting harder to get access to care in Iowa City and Des Moines because of limited beds and staffing issues. There's so many issues that we have to face. We are blessed to have a full-staffed hospital in terms of nursing staff. Our administration has been really adamant about keeping all of our staff employed and keeping staff there so that we can staff all of our beds as often as we can and whenever they're needed. We're always trying to talk about efficiencies in the OR to make that flow smoother so patients can get in and get out and get their care so we can make space for other people. So as a rural hospital with a mindset to serve not just our community, but any community that has the right size care that we can provide, we can get those people in and get them out back to their communities, even try to strengthen their community hospitals so they don't go away, because we can't do that either. But all the things that we talk about, I could talk about this literally for hours. A wonderful question. I would love to talk to you more about that. But I want Taylor and Trish to talk about just the way they're reaching out in OB, and a perfect example of how that's happening.
some people feel, but it is a negative connotation, but sometimes the truth is negative, and that's how we fix it, is by addressing the uncomfortable truths. And so the truth is, in America, unfortunately, the most at-risk, the highest morbidity, mortality in maternal and newborn deaths and complications in pregnancy and postpartum and postnatally are in the minority population, the underserved population, the lower socioeconomic status population, and the rural areas. And a lot of times those all overlap with, being rural, lower socioeconomic status, lower education, minority populations, and that's just uncomfortable to hear, especially as a woman of color, that I have a 4-time higher risk of dying from childbirth just because of being a colored person. So I think we have to address those issues and call them out by name in order to fix them. So in our area, we service from southeast Iowa up into Iowa City. We are the only 2 major delivering hospitals in this area. There's 47 hospitals now in Iowa that deliver. As early as 3 years ago, there were 53. So these hospitals are closing in the areas that are really being affected are the rural areas. And so we have some patients that are traveling an hour and a half just to come to a prenatal visit. And that worries us because if they go into spontaneous labor and they're an hour and a half away, even trying to get to the University of Iowa is a problem. So we're trying to work out ways where we can go to those areas like River Hills and Keokuk County to provide that care so that they don't have to worry about coming to deliver. We're trying to bring awareness of how to prevent disease before you get pregnant, how to lower your BMI, how to care for yourself, so that when you do get pregnant, you're not at as risk, because the services out here are limited. Now, it's not just OB, it's psychiatry, which is a big thing in America, mental health. It's pediatrics. We have 1 pediatrician in the surrounding area. Most of the pediatric care is serviced by family medicine doctors. Again, I think our cardiologist is one of the few in this area as well. Our catchment area is about 150,000 people. So yes, Keokuk County is 10,000, but that's just one area that we service. We service people from all over, and we're very happy to do it, but at the same time, we're seeing our volumes increase, right? We are a critical access hospital, meaning we only have 225 beds, but that doesn't change the volume that increases. And so we're trying to balance that out. And honestly, at the state level, is trying to see if we can expand as a critical access hospital, but also keep that designation, but accommodate the volume. So I do agree with you that hearing the word desert, and it's not great to hear, but at the end of the day, if it helps us come together and fix the problems, I think we should continue to call it as is. I hope that answers your question.
So in my specific training as an OBGYN, Iowa is considered a quote-unquote OBGYN desert because it ranks second to last of the 50 states for OBGYN physicians per capita. So that means access to my services that my husband and I provide in this community could be the only other place that they can go is Des Moines or Iowa City to have those services. And so that's, in my mind, that's kind of how I was, when I was training, when we thought of OB deserts, because I trained in Nebraska and they have the same thing. Lots of areas where they do not have OBGYN physicians. We're thankful that we have family practice docs who can also do deliveries and have extra training in obstetrics. But as far as my training, that's kind of where the OBGYN desert came from, is the lack of people who are specialized in my field that are serving in the state of Iowa. With regards to outreach, my husband and I are working on going to River Hills in Ottumwa. Ottumwa currently does not have a practicing OBGYN. They have what is called locums physicians that come and rotate through, that don't live in the community, but they travel through and provide OBGYN services. So not a boots on the ground service. And so we get patients already from Keosauqua, Fairfield. They're driving, like Dr. Milner said, hours to come and see us. And so if we can even shorten that by just 30 minutes to make sure that they're getting the prenatal care or the gynecologic care that they need, then that's what we're going to do, because that's what's in the best interest of the patients in Southeast Iowa.
And I'll just finish that, because it's such a good question, and then loaded. You're ready. I appreciate what Dr. Miller said and what Dr. Sweet said. Just examples, I think, of what we talk about. The last thing I think is really important is that cancer care in rural Iowa is also really detrimental. We've looked at the cancer registry data and we learned what happens if you are a female that could have breast cancer in a rural community in Iowa. Unfortunately, there's a good chance that your stage of cancer, when it's identified, will be a later stage in rural Iowa than it would be if you lived in non-rural Iowa. And so we've been trying to address those issues, and not just breast cancer, but all types of breast cancer. We have Dr. Dan Colmorgan, who's a surgical oncologist that came down from Des Moines, and he's our cancer medical director at the hospital. We met with the governor last year. We've talked about developing centers of excellence for OB care, for cancer care, for cardiac care. And so he's directing some of our cancer care initiatives to help us do a better job of screening, do a better job of seeing patients, do a better job of maintaining data sets on the patients that we are responsible for. And this year later, we may be in a position to be site visited by the American College of Surgeons to be the first critical access hospital in the nation that's certified to provide cancer care. And so we're talking about this stuff. It's really serious to us. And so just some examples to answer your question, Helena, things we're trying to do, even fighting the opioid epidemic in our own region. I mean, it's really important that people that provide care and write prescriptions are responsible for that. And so those things are all dedicated to providing better health for rural Iowans, especially rural Iowans in our region of the state.
He's going to let me have an expanding question here. Midwives, can you address how Mahaska Health is involving midwifery? We've seen a lot of bills, and on the state level, we see a lot of demand for that. How can that be part of this conversation on OBGYN deserts?
So the conversation of midwives has been a conversation. The conversation of having a nurse practitioner PA, how does that fit and work into the collaborative team that we already have in place with our different skill levels and our different training. I think the hard part is the understanding of what is a midwife. And that is not a simple question to answer, because just as us as physicians who provide obstetric care have different training, midwives also have different training. So is this a lay midwife who has not had a nursing degree, or is this a certified nursing midwife who had 20 years of experience on labor and delivery as a labor and delivery nurse and then decided to further her education? Those two things are very, very different, and that education is very different. So if we're looking at some point to bringing a midwife into our group, it would have to be the right person with the right training to assimilate it into our team of our physicians that we have currently and working as a team with us.
Helena, I wanted to also follow up on that question. So when I was in the military, we had a very strong midwifery program. It was family medicine, OB, midwifery, and OBGYN. And I'm a firm believer that midwives can bridge the gap in rural areas. The unique thing about Mahaska Health is that since we do have family medicine OBs, I'm not saying we fill the gap of midwives, but essentially the benefit that we provide is that our patients can see us every single visit. So if they're my patient, they can see me every single visit and then be delivered by me 100% of the time. Well, no, maybe 97%. Because we do have lives. But, and I think that's unique to our facility. I know that Pella is moving away from that, University of Iowa, and all of the departments don't really follow that protocol, even with their midwifery service line. So I think that's something that's very unique to Mahaska, and that it's not that we don't want to incorporate midwives. It's that right now our model is very specific to that we care to our patients and that we are there with them. You know, sometimes I'm with the patient for 48 hours while they're living, and it's just me and them. And that's something that we have to look down further through the road, but we are very open to it in the future.
Hi there, Scott Williamson, Superintendent of EDF and resident of Oskaloosa. She raised her hand, and I'm going to give her some credit here. Dr. Schwartz Sanders is a graduate of EDF. Go EDF. All right. And I'd also say that I know multiple people that have met Dr. Milner are very impressed provider or coming to the community. And now I'm going to change to a little education side. So we have a shortage, we know, in multiple areas. And this also would go to the sheriff's department. What are things that you think we can be doing to have kids become interested in these professions, from deputies to doctors? As a superintendent at EDF and former principal there, I know that many students, this isn't even on their vision. I remember when Taylor was a junior in high school, and this was stated in a biology class, and Mrs. said that this is the path she wanted to go down. And it's like, it was just eye-opening to many students in our community. What are things we can do or you can do as partnerships to increase students' goals, saying this is possible even from small schools in Southeast Iowa?
Good, Chief.
I was perfectly content sitting up there listening to this panel. With regard to deputies, if you look at my 9 deputies, or 8 right now, but if you look at them, the bulk of them are local kids. They're all kids to me. I value that, where that comes into play for the sheriff's offices. And it's no secret that times are tough financially. The budget at the county is very tight right now. And I was just having this conversation a half hour ago before I came here. I asked one of our youngest deputies, why do you stay here? Because he can go to any surrounding county and make more money. And he said, because this is my home. So I value homegrown kids for deputies. What can we do to help it? The sheriff's office, we have a pretty robust internship program. Not just with Lincoln, not just with Indian Hills, not just with Central College, but we also, under the proper circumstances, if the high school student is 18 years or older, we allow them to do internships with us as well.
Good question, and Taylor's an answer to your question, because Taylor was a student with us several years ago. And so we kept talking with Taylor as a result of that relationship that was developed over several rotations. And being a local person was also an encouragement to us and to her, I think. My new partner, Dr. Jesse Van Manen, that's been present for 2.5 years, was a student of mine over 10 years ago. And he was a medical student that rotated with us as well. And then I was his mentor at the University of Iowa. And I met with him in his residency program in South Dakota. Dr. Drew Richmond is a student that some of you might know from Oskaloosa. His dad is Dr. Sean Richmond. He did a rotation with us several years ago and decided he wanted to be a general surgeon. He signed already to come to Mahaska Health in just 2 more years, 2.5 more years. So I would commend Kevin and even his predecessors. We worked hard 10 or 15 years ago to open the doors to students, to pre-med students, to medical students, to PA students, to nursing students. We have Indian Hills nursing and William Penn nursing students in our hospital all the time. And so the only thing I could say that we could do better would be to have even improved relationships with our superintendents and local educators in high school from Oski, EBH, New Sharon, Pella Christian, Pella, Oskaloosa, everywhere, because we're trying to capture all the students that have any interest whatsoever, stimulate that interest and encourage them to do something like what we're doing. And I think it's kind of fun to watch them come in, because when they come in, whether they become a nurse or a doctor or a PA, they all have a great experience. And we appreciate that, and I think they appreciate that. And I want to commend Kevin and the administration to understand how important that is. Kevin could give you his list of recruitment people. It's a long list. He starts contacting anybody that contacts us, reaches out to high school students in the area that have interest. So a great Christian, and we see the value in that. I was a medical student that rotated through here over 30 years ago, so it works.
Nice to see you again. I think it's been a really long time. I won't say how long ago I graduated. So yeah, I was a student here, and ultimately it brought me back home. But what I love now, my husband and I really enjoy teaching. We have a medical student with us every month. But even more so, I'm seeing our high school students rotating through my OR when I'm operating on my surgery days. And it's so fun to have them in there. And I think early exposure is the biggest key, because I still have medical students who are in their 3rd year of training in medical school. They're getting ready to select their specialty and apply to residency, and they'll still say to me, I didn't know everything that you do in your job. And it's just because of the lack of exposure. They don't get to see it firsthand. And so I think that that's a key component, but also I would love for you to meet my husband because we are both looking into ways to try to get into the local schools and provide education for these students early, because maybe that'll spark someone's interest like it sparked mine, and get them in the healthcare field in whatever role that may be to service the community here at Mahaska Health.
With regard to law enforcement, I told you I value homegrown kids, but I would want to point out to the group that there is a downfall in being in law enforcement in your hometown. I mean, we have a couple of them right here. We got Andrew and Nate. I know they were born and raised here. In law enforcement, unfortunately, we see the bad side of people. And sometimes those people we see bad side of are former friends or possibly family members. So like Nate and Andrew, that can be a bad position to be in. It can help and it can hinder you. You always have to worry about conflicts of interest, that type of thing. Or where it would come in handy is if you have to give a death notification to somebody you grew up with, it can help or it can hurt.
As the only non-native Iowan up here, I will say that when I was moving here from Hawaii has the 50th ranked education system in America, so the worst. I was looking for a state that had great public schools, because studies show, especially as children, studies show that if you have a strong STEM program in elementary into junior high and high school, the likelihood of those children entering into one of those programs, accounting, math, science, in college is high. So when I was researching Iowa, very specifically Central Iowa, Southeast Iowa, had their kids perform 1 or 2 standard deviations above the national average when it comes to standardized testing, which to me was pretty profound, and which is why I also solicited interviews for this area as well. Because knowing that I came from I wanted to be a doctor since I was 5 years old, but I didn't have any mentorship in elementary school and junior high. And even in college, there was nobody saying, hey, this is what you need to do, these are the programs, these are the internships. So I think on the superintendent level and below, we could really focus on getting into these organized groups, just like we have sports and you see what your child is good at, you push them into that area and you just throw everything at them so they can be well equipped to play that sport. It's the same thing with science and medicine. If you see a kid that's getting straight A's in physics and chemistry and biology in high school, that kid could be a doctor, that kid could be an engineer. So I would say from the school level, I would like to see my children be more exposed to meetings and groups that kind of stimulate and make it seem cool to be in those kind of organizations.
Hi, my name is Brent Holman, Ross Lusa. I work at a nonprofit uplifting puppet company whose aim is to make the community a better place to be art puppetry. And my question is about art in the community. When I was getting my master's in community arts, a lot of the research shows that when art is embedded in the community spaces, that it raises both the spirits of the community, but it can also raise mental health and even physical health. And my question is for those of you from Mahaska Health, has there been any consideration of partnering with local arts events like FACE or like other groups to bring more art specifically in the space? I was recently in another neighborhood facility down the road a little bit that had a lot of commissioned work for local artists in their hospital space. So how can we team partner together to make it a vibrant, creative space that can improve health?
Great question. And we just decorated the entire inside of the hospital with local artist photos. So it's really neat. So if you're inside our walls, you'll see pictures all throughout the hospital. But we support local events, and let us know if there's other things that we're missing. We'd love to partner with you. So, and also to EDF gentlemen, we hosted 68 students last year. And so every single year that continues to increase. So we love having high school kids, surgical residents now, also medical students. We have a lot of kids coming through our hospital. I'm thankful that our physicians will take the time to host them and to invest in them. So.
And I think what's kind of neat, what Dr. Miller and Dr. Schwartz both said, and I think you mentioned this too, I think you find those students that are interested in medicine or have the aptitude for that, encourage them. If you find students that are interested in art, those kinds of things, motivate them. And kind of saddle up beside them and encourage them and show them how you can do that. You know, my son is in Indiana at the Jacob School of Music studying vocal performance, and he's going to sing an opera. I didn't teach him to become an opera person. I didn't even teach him to sing. And he's been singing. I'd love to hear him sing. But somebody got a hold of him, and I can tell you all those names of people, and they were mostly teachers and my very energetic wife that motivated him. And so I think all of us should be encouraged by your question, not just for medicine, but also for getting all the students. I have students that come in that have lots of aptitude. It's kind of neat to learn from them about the things that they're interested in. And sometimes we're not even talking about medicine, we're talking about other things. And I can tell you that my son's experience has even changed my focus in my eyes when I see those students. So I appreciate the question, and you encourage all of us.
Which goes on, Mr. Russ. What's the status on mental services or any expansion in the future at the hospital or local areas?
Great question. So we have a partnership with River Hills. They're a federally qualified health center in Ottumwa. And so they're looking at expanding space in Oskaloosa. We actually had two providers that went to go help them. They got a degree in mental health. And so they're now serving at River Hills specifically for mental health care. So we'll continue to work with River Hills on expanding that service.
Also, OB, postpartum and peripartum mental health is a big thing in America, especially in the Mahaska County. The highest chances of a woman committing suicide after having a baby is in the first 3 or 4 months. And so we're compiling a list of all the perinatal resources we have in the state and also on the national level. We try to give those resources out to women before they deliver and checking in with them with each visit to make sure that they're doing okay. For all of you that have children, grandchildren, great-grandchildren, you know that period is very delicate for a woman. And sometimes people just kind of underestimate women's mental health, because if you battle with postpartum depression or anxiety, you have like a 35% chance of having that for the rest of your life. So we do recognize the importance of mental health, especially in our female population. Also, and I've brought this up a lot, I'm doing a lot of adolescent medicine psychiatry. I mean, I'm prescribing antidepressants and anti-anxiety medications that are like an all-time high in my career. And I mean, I've had veterans and active duty soldiers that would have PTSD, and even now, I'm prescribing more medications than I ever have. We really don't have that many mental health psychiatrists, well-trained mid-levels that can provide therapy. And when I say therapy, not just medications, like cognitive behavioral therapy, coping strategies for our teens and how to overcome bullying and social media, all kinds of things. That to me is a high priority because between Sharon, Oski, Hella, Eddie, like these high school kids are really suffering, and we see that, but we really don't have the financial resources, because to get a psychiatrist or a well-trained mid-level here is expensive, and even that, if we have just one, but you're inundated with so many patients, you're like, well, how can we balance this out? So I think that's a great question, and I definitely think that that's one of the biggest areas we can expand into in Southeast Iowa. But the University of Iowa is doing a great job of providing televideo. They accept any insurance, especially for maternal care, for perinatal psych, and it's a great resource. If anybody needs it, we can always give you those resources. But I agree with you, mental health is a big priority.
One other thing, have residencies that are training physicians to become psychiatrists in the state of Iowa, you have a better chance of keeping those residents in the state of Iowa. So the more residents that we're training in that field, the more we're going to see staying in our state.
Vinny, you brought up a very hot topic, you might say, a very important topic in Iowa, and has been for several years now. I think we can all agree that more can be done for mental health. And it's not just in Mahaska County, it's statewide, it's nationwide. You've heard of the opioid settlement. Mahaska County did get money from the opioid settlement. I wish Arthur was here because he could help fill us in more. So the Sheriff's Office, the Police Department, and Mahaska Health have partnered, and a decision has been made, I believe, by the Board of Supervisors on how part of that opioid settlement will be used. Very close to it, down in Wapello County, they have I believe she's a CEDA employee, she's a home girl, she's Mahaska. She works full-time down in Ottumwa and Wapello County. Her job is she rides with law enforcement, the Ottumwa Police for Wapello County, and she responds to every mental health call they have, as long as it is safe for her. And she's a liaison. So up here, we don't have that position. We run into someone having a mental health breakdown or in crisis mode, we have to take them to the ER and that type of thing. This position down there, she has other options other than taking them to the emergency department. Well, not counseling, not therapy, but she knows the different resources. So as part of this opioid settlement payment that Mahaska County is receiving, we were going to try to get a part-time position of that nature here in Mahaska County. A young lady was selected. I wish Arthur was here to discuss it. But before we could get her trained and going, riding with us, riding with the police department, she accepted another position somewhere else. So I believe Arthur is still looking for another person to act in that role. I wish we could make it full-time. The program down in Ottumwa, if you talk to anybody at Ottumwa Police or Wapello County, she is a huge asset. There's a time that we have to take people suffering from a crisis to the ER. But we're not medical professionals. We can't make that determination. If we had a position of that nature and other resources available, it would help make that determination.
And thank you, Russ. And I think it's not just a health problem, it's a public health problem, it's a community problem. It's not just a rural problem, it's a national problem. And so we don't have answers. We had a psychiatrist here several years ago, a good friend of mine, Dr. Zella, and he's now passed away, bless his heart. A great man, he did a lot. He found out how challenging it is to provide healthcare services of that magnitude in a rural community and even in the community that he moved to. And so it's a huge problem, and I encourage politicians, and I encourage community leaders, and I encourage educators and education leaders and families, and we all need to address this problem. It's not an easy problem. It's just as different as having a C-section is from an appendectomy. There's every age, every gender. It's a huge problem, and so it's one that we can't address here, but we would love to address it.
Right, also Oskaloosa. So about 6 months ago, the AG was here in Oskaloosa at the hospital. We were talking about a program to help reduce drug overdoses, drug use. Can you give us an update on how that's happening or what's going on with that at Mahaska Health? And second of all, how the hospital is working with law enforcement, others in the community to help reduce drug overdoses, drug use, and what kinds of things maybe the community can do to also help out you guys in that capacity?
I'll just address the first part of the question. We've got that program going full swing. So we have all of our surgeons that do surgery at the hospital. We're trying to reduce the number of opioids that are administered after a surgical procedure. And so we've gotten that down to where I wouldn't have the statistics for it, Kevin may, but the number of opioids that we prescribe is an order of magnitude less than we've ever prescribed. Personally, I've not written a prescription for narcotics in probably 4 years. Not that that's right or wrong, I just learned that what I had been trained and what we always had felt was appropriate care. It used to be 10 years ago that if you didn't give narcotics, you weren't providing good care. You weren't managing pain. Now I have long talks with patients about how to manage their pain with not using opioids. So many of my patients now wouldn't take the prescription if I give it to them. And so we do all kinds of things. We call it ERAS, early recovery after surgery. Opioids happens to be a big part of that because if you do surgery and then you give somebody opioids, they have a slower recovery. Their GI system shuts down. Everything just kind of, you go to sleep for a while, you know. So it's kind of like going to sleep until your pain's done. But you can do it with other things, non-steroidal anti-inflammatory medications, Tylenol, other things that control neurologic pain. We give a whole host of things before surgery. We do things to get people's GI tracts working after surgery quickly, and we also limit the number of opioids that we administer after surgery so we don't have some of those challenges with people that are coming back to the ER because of constipation and belly cramps and tiredness and all kinds of things that opioids can give, not to mention the fact that we've learned that if you give somebody an opioid prescription, somebody else in that house has an opioid prescription, the chances for somebody else in that house becoming addicted to opioids is dramatically increased. So being responsible for that has been a huge issue for us as well.
To answer the second half of your question, Ken, is we've got a great partnership with police, fire, sheriff, deputies. And let me use an example. Officer O'Day, prior to an experience he had, is he purchased his own tourniquet. He thought he might have to use it at some point. And just a couple of weekends ago, there was a patient that was bleeding out. He put his own tourniquet on this patient in partnership with our ambulance service, paramedics. They came into the ER, and Dr. Breon, Dr. Vermonen took care of him, saved his life. And it started with O'Day, Officer O'Day. And so now, as a hospital, we're going to provide tourniquets for our police and sheriffs and deputies as well. So things like that, we're going to continue to help each other.
Ken, you'll notice since the start of the discussion up here, opioids has been mentioned several times. And I don't know that, so if anybody in here thinks that there's not an opioid problem in Mahaska County, they are very mistaken. I'm not saying it's the prescription opioids. Fentanyl is here, and it's vastly present here. We, not just police department, sheriff's office, we all carry Narcan. Okay, it's a drug to counteract an opioid temporarily. You ask how we're working with Mahaska Health is we as first responders, we do and have used Narcan a lot. Okay, and have been able to successfully get heart beat back, get them breathing again, but that's a short-term fix. We have to have an ambulance there to get them to the hospital because the Narcan will wear off much quicker than opioid will. They need to continue to get doses of that. It's not just in pill form. It's that, they're mixing it with meth here. They're mixing it. It's in the vape products now. It's a horrible problem. We started at the sheriff's office. We started using Narcan about the same time the police department did. And I can remember back in 2017. Boy, I was given the devil. I know the chief at the time was just given the devil. Well, how can you enable these dopers, these junkies, by doing Narcan, you're just enabling them. Well, I don't care, in my opinion, I don't care if it's enabling them or not. That is somebody's granddaughter, that is somebody's grandson or son, and if we can save them to get them the treatment they need, on behalf of the sheriff's office, we're going to do it. We made a few changes, thanks to CETA, just here in January at the jail now. In addition to our deputies carrying Narcan, we're now carrying, doctors might have to help me here, Cloxado. It's double dose of Narcan. It's twice the milligrams of Narcan, same. So when we use Narcan on an opioid overdose, it's a nasal. We shoot it up their nose. Give it a minute or two. If they don't start to recover, we do another dose. And the whole time we may be doing CPR, we may be breathing for them, chest compressions. I believe the record for the sheriff's office, I hate to say it that way, record is 6 doses. before it actually works. Kloxxado is twice the strength of Narcan, so we're using that. CETA is enabling us at the jail. And, you know, I mentioned in an earlier comment, unfortunately, we know the bad things about people in our community. And we know who many of our opioid addicts are in Mahaska County, in Oskaloosa. The new program we've started at the jail is, if we know one of them addicts is in our jail, let's say they're running for driving under suspension. They have to spend the night in the jail. We know that because they're an opioid addict, one of the first things they're going to do when they get out is go seek the opioid. We're going to provide Narcan to them on the way out the door if they want it. Is it enabling them? Yes. In my opinion, if it saves their lives, it's worth it.
Yeah, my name is Bob Leonard. I live down by Hussey, and I'd like to follow up on the mental health question. I think this, everybody there will have an opinion on this. You're all talking about needing more resources. And I know your ERs, I know the sheriff's office spends a lot of time, and the police department spends a lot of time working with mental health patients. And I know there's these regional centers, there's those people who transfer people to it, and they don't work very well. In a time when the legislature is considering budget cuts, and yet you need more resources, how should we speak to our legislators? What should we ask them? How to help you?
That's probably a better question for Helene back here. Bob, yes, it's going to take funding. So, in my view, when the problem began years ago in Iowa, when the governor at the time shut down, I think it was 8 mental health facilities across the state. I had worked for several years prior to that point. The entire system for mental health and law enforcement has changed. So back in the 80s, if I ran across someone in a mental health crisis and I felt they were a danger to themselves or to others, I would take them to the hospital. The ER doctors would examine them, and they determined the same thing. Yes, they're a danger to themselves or others. Then we would reach out to a judge. A judge would order an issue for us to take them to a facility somewhere here in Iowa. At that time, that facility had no choice. If a judge issued an order, they had to take it. We don't have those 8 facilities now, and it's all changed. Any mental health facility across the state, they determine whether they want the patient or not. I don't know what criteria they use. I can tell you this, that many of the mental health issues are brought on from substance abuse. And some of the mental health facilities in Iowa, they don't deal with substance abuse. I don't know what the answer is to get more funding. I wish I did. I knew Dr. Zella, wish he was still here. These gentlemen know my thoughts on getting a local psychiatrist here. But I don't know how to get the funding.
I think the short answer to that would be, since we can't ask for more money for salaries for mental health providers and physicians, is to utilize the people that are already here, OBGYN, family medicine, general surgeons, in a way that we're all trained to at least handle it on a day-to-day basis. Because if you see a therapist once a week or once a month, but you can see your local family doctor or OB or general surgeon more often, then I feel like I'm more equipped to take care of mental health. I feel comfortable taking care of mental health in adolescents and geriatric and, middle age, but some people aren't. And with that said, some of the programs that they have implemented where they bring in nurse practitioners levels or PAs, I can say that I don't necessarily know if they're truly trained. And I've seen that with the perinatal site too. I don't necessarily know if the resources that have already been provided are adequate. So I would say enhancing the training of the ones that they've already pushed out, the state has already allowed to push out, would probably be more beneficial, more effective, and more efficient. So that's the quick fix would be mandatory CME for all of us on how to prescribe, but not only prescribe, how to provide therapy. There's some instances where the family medicine doctors are seeing people, and it's a 40-minute session, while that takes a lot of our time, studies show that if you have medication and therapy at the same time, it works better, the effects are better. So I would say at the state level, we could ask for more education training, just like with the opioid. There's this mandatory 8-hour training that we have to do to be more well-versed in how to prescribe and control opioids. It's the same thing with mental health. I can say that when I get a patient from an outlying mental health facility, and then all they offer are like 6 different medications and there's no therapy being done, that's a problem. Right? You can't throw medication at a problem and think it's going to be fixed. So I would say it's just more training for the trained professionals, and that's easy. That could be a online training, that could be a group training, but unfortunately that's just the best I think that we can do at this point.
And good question. I think an answer, just to answer your question, would be if you're going to write to your state legislators, you can maybe use this term. We'd like for them to discuss how to right-size medicine for mental health and psychiatric care. So one of the things that we deal with as physicians is that we oftentimes have people that come in with acute illnesses that we don't have the resources to manage. Not just mental health, but anything. Sometimes it's a bad car wreck, sometimes it's really a terrible illness. And so we are a critical access hospital that doesn't have angiography services. We don't take care of heart attacks here. And so we have to have those services at a position where, and the process of getting them there as quickly as possible. We do that for stroke care. We do that for MI when they have an ST elevation. We do that for specific things where somebody has been targeted and trained and has the resources to take care of acute issues. Ask them for places to take care of acute mental health issues. Tricia's talking about chronic health issues, mental health issues. We all have to be better versed at taking care of those. But there are people that come to our ER, and sometimes they get stuck in our ER, and they truly have an acute mental health issue that needs to be provided in one of these services, and that's one of the things that the budget cuts have taken away. They've taken away the ability to provide acute mental health services, and we need that. So if you're going to ask for something, ask your legislators to re-examine the thought process of how we manage some of these acute mental health issues, right-size medicine for mental health, but also for everything, because we even sometimes have more trouble transferring those acute patients to tertiary care centers than we've ever had because of their limited resources and mainly beds and staffing.
I'm Kirsten, I'm the director of pharmacy at Mahaska Health in Kenwood. If you don't mind me responding to some of the opioid-related questions. We have an opioid stewardship clinic at the hospital where we focus on opioid prescribing, ways that we can help our patients, be it move medications from the narcotic realm over to a more appropriate medication to help with those pain managements that are opioid medications. We focus on naloxone prescribing for our patients who do have opioids prescribed that are pain management medications. We focus on making sure those patients have naloxone available in the home in the event of a potential overdose. Also, with the surgical program that we implemented, we decreased opioid prescribing by over 1/3, which is huge for our community as well as our patients. And if the prescribing is still necessary, the quantities are lowered so that our patients don't feel the need that they have to take all of their medication and lead to potential overdoses or, just real blank, dependency on medications.
Yeah, I would just say to that, we also, pain is a real thing. We have a pain management specialist, Greg Kronenberg, who comes down and he spends his days talking to people about their pain and finding alternative ways to manage that as well. So.
Last question. Hi, my name is Kevin Runkle. My wife and I are from California. We purchased a property here in town. I'm not sure why entirely, but we're here. I want to say thank you all for stepping up and doing what you're doing. As somebody who travels the country consistently and sees these issues from border to border, north, south, east, west, they're happening here at a grander scale. And so, just to piggyback back off the gentleman's question he had before, what do we ask our state legislation, you, what should we ask ourselves here in hospitals on what we can do instead of just looking out towards others to provide budgets? What can we do here? And what are the questions we can ask ourselves to help this process?
Great question. I think the real key that all of us can do is if you don't have a primary care provider, if you're not established with someone and getting a yearly physical, a wellness check, that is crucial. We're seeing a lot of stage 1 and 2 cancers now because of the work our providers are doing versus stage 3 and 4 cancers. So that's the key.
Yeah, nobody likes to go see the doctor, me included, but screening is so important. You know, taking responsibility for your own health is so important because the more you neglect your own health, then the more of a burden you put on the health system when you finally do come in, and then you take away the ability that we have to provide screening services and preventative services for young people because we end up having to take, it takes a long time to take care of somebody that has a delayed medical issue compared to just screening for it and preventing it. And so I would tailor that. And then I also think just, you know, really being accountable to somebody. Being accountable to somebody that you love and care about. You know, having a great relationship with them where you can take information and give information so that you can be encouraged to do your best. I always encourage medical students, when you walk out of the hospital at night, when you look at the doors, ask yourself if you're ready to go home. Have you committed to do something before you've gone home that you haven't done, and go do it? Because if you decide not to, then it'll be hard to do it the next time. So that goes for all of us. Just check yourself.
I'm going to interpret this question just a little bit differently. Get out and vote. Like, talk to your legislators. They are your voice, and find whatever you're passionate about and make sure you're communicating that with them so that they understand what their constituents are asking for so that they can truly be your voice when they are casting their vote. I say that as a person who wrote my legislators in Iowa for the very first time last night. I wrote my senators because there's something that I'm really passionate about that they're voting on, and I want them to know how I feel. So take your voice and use it. Whatever that passion is, it doesn't have to be healthcare. Just use your voice and make sure that your vote is heard and that your voice is heard, because everybody deserves to be heard.
From a law enforcement standpoint, what can you do? Okay, so we talked about addiction today, we talked about mental health. In law enforcement, we deal a lot with behavioral issues in our schools. So what can we do as parents, as grandparents, is understand if you have a child or a grandchild suffering from mental health, suffering from an addiction, suffering from behavioral issues, don't abandon them. My personal belief is I'm a parent until the day I die. I don't care what my children do. I'm not going to abandon them because that compounds the problems. So just know that I feel it's our responsibility as parents and grandparents to always be there. You may want to call it enabling, but it's our responsibility to always be there for our children, no matter what their issue is, children and grandchildren.
I'm just going to say everything they said, plus as a family doc, I will say, if you're not seeing your doctor every year, that's where we screen you for mental health. Even if I have somebody that's completely healthy and I screen them and they're depressed, you're not healthy all the way. So that's the best way to reach out for help. Is sometimes we're the only access to care. Sometimes I see people who are in a very bad social situation, domestic violence, or even abuse, parental abuse. So I will say, see your doctor every year, once a year, even if you feel healthy. And if you don't, this is why I tell my patients, you can't complain if your care isn't being adequate, if you're not being proactive about your care. Because all I can do is, when a patient says, well, I don't want to vaccinate my kids, what do you think? I'm like, well, it's not my kid. And the same thing, it's your body, it's your health, it's your state. So like Dr. Schwartz said, if you don't advocate for all of these things, then whoever is controlling them will make the decisions for you, and your hands will definitely be tied. So thank you.
That gets us to the end of our time this morning. I want to say a special thank you again to everyone who's been involved with this. So thank you to Midwest One for the free coffee this morning. We thank Smoky Row for this facility that we're able to be a part of and enjoy. We say is thank you as well to the media who is here, that making it known that this is an important time and a good place to spend your time. And especially thank you to our panel here. They all have tough jobs, they're on call 24/7, and they're here today to help enlighten us as to what the issues are in the community. So we thank them, and we also want to remind you that we'll be getting together again for coffee and conversation 2 weeks from now on the 23rd. That will be with our state representatives and state senators. Thank you, especially to you for being here and making this a successful event. Have a good day.
Right away, create